Kia ora. My name is Alex Sirides. I'm an intensive care consultant at Wellington Hospital, and I'm the clinical lead for the Patient Deterioration Programme for the Health Quality and Safety Commission of New Zealand. I've got 20 minutes to talk to you about the New Zealand Early Warning Score and why at the end of the programme we are now in a position to validate that what we did actually works or not. This may seem like a strange process by which essentially we have implemented a national system-wide change, but for a variety of reasons that will become apparent, we're only now at the end of it able to take a step back to see whether it actually worked. So many of you came with us on this journey, for which I'm grateful. What I hope over the next 20 minutes is to provide some hopeful reassurance about when we set off what we didn't know we would end up, but we have ended up in the right place. I was also supposed to be presenting this talk with John Hewitt, who has been instrumental in validating the New Zealand Early Warning Score, but unfortunately he's currently saving the South Island from COVID, so it wasn't available. So my apologies, but I need to give credit to him, which I will later on. This comes with a warning by nature of the fact that we're talking about validating massive data sets. There is some statistics. I will provide a brief explainer of what it is I'm going on about that hopefully will clarify some of them. But if you are afraid of, understandably, statistics, then please go off, make a cup of tea when that slide appears. Anyway, we shall progress. So, as with all these stories, we must work out where we began. We began essentially with chaos. For a small country, we appeared to have no idea about how the best way of detecting deteriorating in patients actually was. Every DHB, to its credit, had an early warning score system back in the early 2010s to 2012s. But we decided before we set out on this work to try and work out how New Zealand was using these systems to detect physiological deterioration in adult inpatients in hospital. What we found at that point was that all DHBs who kindly responded to our request to send us their vital sign charts, essentially there were 21 systems within 20 DHBs, and there was huge variance about how we were detecting deterioration in adult inpatients. There were up to 9 different physiological parameters scored, with the total maximum score available ranging from 5 in those that scored less with lower scores to up to a total score of 24. And this chaos, I suppose, seemed illogical at that point, given the number of hospitals there were and the size of the community we were talking about. So we wrote this up as a paper mainly out of interest to show that there was no conformity around how we'd done this. It's not too surprising, given that everyone essentially had made up their own early warning score, which is admirable, but equally it seemed there was no, at that point, clear evidence base about which was the best one to choose. It also seemed to physiologically not make sense. It's as if the residents of Timaru have a different physiology to those of Northland, which physiologically seems extremely implausible. So why should there be this inequity of escalation if you were to deteriorate, depending on which scoring system you were fortunate or unfortunate enough to be subjected to? So when we looked at this, all we saw was confusion, but confusion with its heart in the right place, which is clinicians trying to do the right things for their patients. So we started looking at how we could make this better. And this single paper essentially was the argument for our case for change. So when we started the early warning score system in Wellington, we were struck by 2 particular ways of approaching this. There seems to be a geographical preference for how patients were detected. In Australia, the long-established medical emergency team dating back to the mid-90s that was first described in Liverpool in New South Wales had come up with a concept where rather than waiting for patients to arrest and then calling for help, a pre-arrest team then called the medical emergency team in this first paper from Ken Hillman's group, describing single parameter extremes, such as a systolic blood pressure less than 80, a heart rate over 130, which then dispatched a team of experts, critical care nurses, intensive care doctors, and escalated essentially an all or nothing response once you breach this. So the single parameter descriptions of breaching one rather than multiples seems to work well. There's a subsequent number of papers that report essentially less cardiac arrest because patients are attended to more rapidly. This was slightly different to the system that was being developed in the UK. And in 2010, the paper that would subsequently go on to become the National Early Warning Score, or NEWS as it's now known, was first published by David Prothur's team, which essentially was based on a massive electronic data set that allowed them to take vital signs that were linked to outcome to work out what was the best way of detecting deterioration in patients. So they relied on a series of vital sign deviations, each of which had a score, and the score was added up, and that score then triggered a response. So both these systems had advantages to patients. They both trigger an escalation, which is essentially to a group or individual who has more a larger skill set with regard to dealing with deteriorating patients, in the hope that this could be stopped and reversed. But it seemed that each of them, aggregate scoring requires numbers to be added up before the action can be taken, and single parameter calling is pretty obvious if you breach a line on a chart and doesn't require maths to work, but also doesn't allow any pre-escalation. You either are in the escalation zone or you're not, because they're based on single parameters. And it seemed to us when we were developing the system, at least in Wellington, that there were advantages to both of these. So what we did was take what we thought were the best things. We took aggregate scoring, where small deviation in multiple systems would give you a similar response, for example, for a single extreme deviation in any one system. And we took both of these and added them together to combine them into the New Zealand Early Warning Score. And those of you obviously familiar with the charts will have seen this, where a small number of scores added together can cause an escalation that is equivalent to an extreme single parameter. So both of those working together, in our minds at least, seem to provide safety for patients. It's worth pointing out that at this point, electronic vital sign capture systems in New Zealand were very much in the minority. And of course, such systems mean you don't need single parameter calling, because the score is always added up correctly and always tells you what you need to do. Human factors being as they are, is that if there is a chance to underscore people, then we will. So we know from a number of observational studies that clinicians, given the choice of choosing a number that breaches a trigger threshold to make something happen, or not choosing that number, they will invariably choose not, because generally speaking, people don't like to call for help unless it's really apparent that this is absolutely the only option that they have. So we'd hoped at this point the aggregate scoring part was safer, or the safety improved on a paper chart by adding single parameters. And this obviously led to the New Zealand Early Warning Score that you're familiar with. We have a graded color scale that was chosen based on human factors design. We have a step from red to blue, which is a cognitive shift, because this is where you're crossing a threshold into much higher mortality patients. The concept of blue as an escalating criteria for code blue patients, etc., is well established within medicine. And also there's a cognitive shift, as I said, from having to do something different. We read a lot around human factors design about red has psychological connotations of stop or do not do something. So having red as an extreme parameter introduces some subtle cognitive dissonance around stop as opposed to go. These may sound nonsensical, but under psychological testing conditions, when human factors in regard to making people do the things you want them to do have been considered, it has been described that red generally should probably be avoided if possible when you want someone to actually take an action. So when we started this, the first question really was, how did we know this would work? We sold this to the HQSC as a 5-year program, which is why you're ironically now listening to me talking about it. But when we started, there was a major caveat. We didn't know this was going to work. So this seems like a fairly dumb thing to do, to take a system that is in place in every DHB and say, no, listen, you need to change to something else. But there are a few things we used to convince the commission and also to convince ourselves we were doing the right thing. This is one of them. This was our experience in Wellington Hospital, where we introduced the early warning score back in midway to 2009. And what you can see, hopefully on this graph, although they have different axes, is that the cardiac arrest rate on adult inpatients fell from about 4.5 per 1,000 admissions to where it now remains at about 0.8 to 0.9 per 1,000 patient admissions. And it did this by means, hopefully, from a causation effect rather than just correlation, of increasing MET calls. What we have noticed as our system had matured locally was that even though the number of Met calls started to diminish, the cardiac arrest rate has remained low. And this is the system certainly that's been described in Australia, where mature systems have now essentially increased the capability of not Met-based responses. That is a feature of aggregate scoring that allows others to continue to manage these patients and essentially stop people deteriorating to the point at which they have an arrest. So this was the first score, the first evidence that this system has some potential to work. And this was essentially designed with Jenny Hill when she introduced the patient at risk service in Wellington Hospital. We were greatly influenced by Dr. Alison Pirrett's work within Middlemore, having described their patient escalation system as well. The other part of this was obviously that we had to sell this on an evidence base. And before we could go around asking everyone to stop doing what they were doing, we had to tell them that we had a system that was better. This was relatively easy because most people's systems had been presumably sketched out on the back of an envelope. There wasn't any evidence to support them other than experts saying this is where the line should lie. What we had at this point now was the VIEW study I talked about earlier, which at that time was the largest published evidence base for the largest electronic vital signs database. They had a total of 200,000 vital sign sets for over 35,000 completed medical admissions that was outcome linked, that allowed them to predict if the patient or a patient for a given set of vital signs was dead or alive within 24 hours of a given set. And they compared 34 different early warning score systems to allow them to come up with views that subsequently became news that was the preferred system as having the best ability to predict adverse outcomes from a given set of vital signs. So we had this evidence base to use to recommend the New Zealand Early Warning Score as a constituent. And there are a few things about this that I'll come to later, but the predominant one is this actually was a single centre study just in a medical admissions unit. So this didn't include surgical patients, it didn't include other centres. But this was enough evidence for the UK to implement a national system based on one study. So to understand how this works, we have to delve into the murky world of statistics. And this is a relatively simple graphic, hopefully, that allows us to understand the difference between a true positive, a true negative, a false positive, and a false negative. And these concepts need to be understood with regard to how we've actually validated the New Zealand Early Warning Score, and how, in fact, almost every early warning score system has been validated using massive vital sign database sets. As you can see in the top left, a true positive is a patient who is both pregnant and the test tells them they are pregnant. On the top right, as you can see, it's unlikely this elderly man is pregnant, so the true negative is you are not pregnant. So those are both what we want our system to do. We want it to only detect true positives and true negatives. We only want to escalate patients who are deteriorating, who actually are likely to have bad things to happen to them, and we don't want to escalate patients who are going to be fine, because that means you're wasting system resources. The cry wolf phenomenon starts to appear and people just simply stop calling for help because they don't need to do anything. When it comes to false positives and false negatives, also known rather confusingly as type 1 and type 2 error, you can see, for example, that a patient who clearly is not pregnant being told they are is a false positive, and a patient who clearly is pregnant being told they're not is a false negative. Now, these in this system will cause harm because it means patients who are deteriorating, who are not escalated, will come to harm. So this needs to be considered when you're testing the sensitivity and specificity of this system in detecting deterioration. And the way this works is a rather curious statistical anomaly. After the Americans were bombed in Pearl Harbor, they used radar to develop subsequent incoming fighter planes and bombers. But what they did was they developed a test that determined whether radar staff were able to distinguish between planes that meant that other planes had to be scrambled to attack them, or, for example, large flocks of birds where planes were a very bad idea to fly towards them. So what you have is a true negative and a true positive, and you have a threshold in your test where to one side you have a true negative if the test is negative, and to the other side you have a true positive. And this really works best for tests that are binary. So, for example, within 24 hours, the patient will either be dead or will not. There's no middle ground between those two. And ideally, for a perfect test, this, what is called the area under the curve, equals 1. So, for example, for this test here, where you can see that whatever the test shows, the two curves are completely separate. If you then plot what's the true positive rate on the y-axis and the false positive rate on the x-axis, you end up with a square box where the area under the curve equals 1. So for a perfect system, your test distinguishes 100% of the time between patients who will deteriorate and patients who won't from any given set of vital signs. And that essentially is what the statistic called the area under the receiver operating curve is. It's the ratio between the true positive rate, the false positive rate, and the curve that's plotted in the area underneath it. And if that area equals 1, you have the perfect system. So let's look at what the UK did before they implemented the National Early Warning Score. So this is these are three papers, three early warning score systems that they compared using their data set. And essentially the one that is the highest and to the left is the best system, i.e. it only picks up people who are deteriorating and doesn't pick up people who aren't. And that's related to the number, the 0.888 you can see in the top left-hand system there. So that at the time this was published was the highest rating for an early warning score system that was available, which is why it went on to become the national system. Using their massive vital sign data set, they're also able to produce things like this, which is you can see the view score on the x-axis, and you can see the percentage of observations at that score on the y-axis. You can also see the percentage mortality. So what this shows us is that the majority of people have low early warning scores, which is good, but also as the early warning score gets higher, then you have more chance of dying within a given period of time from that set of scores. Represented graphically, essentially it breaks down like this. So this is for the UK data. If you have an early warning score of 1 to 5, that applies to about 60% of patients, and within 24 hours, a range of between 0.3 to 1.5% of patients will have died. As the score goes up, for example, once your score reaches 16, there is a 43% chance that the patient will have died within 24 hours. So what this helped us with when we were designing the escalation pathway was that 95% of patients scored 7 or less. This isn't a system that overwhelms the resources available, but it does mean that patients with higher scores should have more care provided to them. So this was the context we were in. This is John. He is the king of data. He was instrumental in allowing us to perform this work. As I say, he's currently vaccinating the South Island, so he isn't available, but I genuinely want to recognise the work that he's done in making sure this team, him and his team, I should say, making sure that what we've done has actually been beneficial to New Zealand. And we couldn't have done any of this without him. So huge credit to John. So early on, Canterbury have the patient track system, an electronic system of vital signs that allows them to capture data on every patient. He sent me this back in 2018 to show that as we'd started to implement the New Zealand Early Warning Score, that the frequencies that were expected from the UK paper were not that dissimilar, at least from within Canterbury. These line up with the chart. You can see the grey bars at the top are actually white. So this is the 0 score. Yellow scoring 1 to 5. You can just see tiny little orange blips and then red and then blue right at the bottom for the MET calls there. And at this point, they're requiring 3,500 early warning score sets per day. So this was an early sign that, at least in Canterbury, things were working as expected. So that leads us to the next question, which was a question I was quite scared of asking, but we absolutely needed to, which is, does what we've actually done work? And as I've shown you, we have a single center study, which was the Wellington implementation, and we have the backup of the early warning score validation in the UK. So what did we do? Canterbury went to their vital signs database, which they made available for analysis by their business unit. And they obtained a series of 14 million vital signs over 589 days that represented 1.8 million complete vital sign sets. Now, the size of this data is staggering. This will be, when published, the second largest vital sign data set ever conducted, analysis ever conducted in the world, at least within the literature as we currently stand. And this has all come out of Canterbury, for which I'm extremely grateful. What they reported was 102,000 admissions across different hospitals within Canterbury DHB, with all hospitals contributing, obviously the bigger hospitals, the main Christchurch campus contributing disproportionately. But they also contributed from all specialties, which were essentially medical and surgical, and the eligibility were for completed adult inpatient admissions. So completed, by which I mean we knew what the outcome of that admission was, and it was for adults only because we're only validating the adult early warning score system here. And you obviously had to be admitted as an inpatient. Breaking the data down, because these data were analysed for every given set of vital signs, there was a National Health Index number, an NHI assigned, that allowed the analysts to work out what happens to those patients using the patient administration system within a fixed period of time from any given vital sign. And the three adverse outcomes we use are those that are well validated internationally of ICU admission, cardiac arrest, and death. And we compared these with news for same for the analysis as well. Now, what you will see is that unlike the UK data set that was used to validate their system, which was all medical patients, we had a relatively even split between medical and surgical, with older person and mental health patients included in here as well. So essentially everyone who had the vital signs done and patient track was capturing both that set of vital signs and the outcome. You may remember this graph from just now. This was the UK data showing how the scores were distributed in the mortality, which now having access to the Canterbury data meant we were able to reproduce. Now, what you can see is that they are relatively comparable. Given the nature of some of these patients in other areas and not in the tertiary centre in Christchurch Hospital, you can see that there are more patients scoring 0 than there were in the UK centre, which was a medical admissions unit, so patients presenting because they are unstable. When you're including surgical patients, as we have, who are also having elective surgery, it's not surprising that there are people with lower early warning scores. What we saw is that the breach of 10% mortality, which is an arbitrary line, was essentially crossed once the New Zealand early warning score was over 13 for the average of patients. So slightly higher than had been reported in the UK of 10. But again, this reflects the fact we've included surgical patients. What you will hopefully also see here is that this data set is using 1.8 million vital signs. So the Canterbury data set is 9 times bigger than the UK data set, which was used to implement a national early warning score system. Because we have these adverse events linked by NHI, by absolute numbers, you can see for the patients who were analysed, these are the numbers of events. There were 810 people who died within 48 hours of a given New Zealand early warning score recorded. 51 patients had a cardiac arrest within 24 hours, and 727 were admitted to ICU unplanned within 24 hours. It's important to distinguish between elective ICU admissions and emergency ICU admissions. All elective ICU admissions were removed from this data set because these were people who had beds booked after major surgery, so the early warning score is irrelevant to them going to the ICU. So, how did we do? The simple answer is that the data set that John's team analysed in Canterbury shows that we have essentially managed to produce the most sensitive, most specific system yet described in the literature for predicting deterioration in patients. Now, what you can see, because we have now analysed by both medical and surgical patients, is that for the first time we've breached almost close to the not quite perfect of 1.0, but extremely high best performing system in predicting death in surgical patients. So you can see there the number that's highlighted in red, the statistic of 0.910 is pretty close to 1. What's interesting here is the discrepancy between medical patients and surgical patients. And essentially, again, I think this reflects the fact that surgical patients are diluted by elective surgery, where vital signs are likely to be normal. So when there is an abnormality, it's much more predictive of an adverse event. In patients admitted for medicine, where every admission is an emergency because there aren't elective medical admissions generally, it is less likely that your vital signs, where you may be chronically unwell with hypoxia or hypotension or hypertension or tachycardia, is actually going to predict an adverse event. So I think that's probably the discrepancy between these two criteria that we see here. But what we have done is shown that, in summary, that the UK system essentially is equivalent, and the New Zealand system actually exceeds it, at least with regard to predicting adverse outcomes in surgical patients. There is one strong proviso that needs to be put in here, and that relates to the ethnicity of patients within Canterbury DHB. As can be seen from this graphic taken from the Ministry of Health website, Māori and Pacific patients are underrepresented within this data set compared to the national averages. So we need to bear this in mind when interpreting these data for our Māori and Pacific patients about how well the New Zealand Early Warning Score works in this context. This will be a separate piece of work that we hope to continue to analyse outcomes by ethnicity. As you can imagine, the amount of work that had gone into getting this far to even validate the system means that this is quite a complex analysis, as an extra layer will need to be added. but we hope over time to complete this analysis and report these data when available. But as we stand for now, at least, we can see that the Canterbury data set shows for all New Zealanders that it is more specific and more sensitive for detecting deterioration, specifically for surgical patients. So to summarise where we're at, we've now validated the New Zealand Early Warning Score in New Zealand patients in the New Zealand healthcare system. We have shown that the early warning score system we introduced nationally is equivalent to news for predicting adverse events in the UK and superior for some, particularly surgical patients. And where we're up to is that once published, and the paper is currently has been submitted to a journal for consideration, it will be the best published performance of any early warning score system for predicting adverse events in surgical patients. So I want to thank everyone involved in this data analysis, the team at Canterbury, John in particular, and my colleagues who have helped write this up as a paper for publication, particularly Cormac as the first author. When this is published, we will distribute this to the relevant groups. So hopefully you can now be reassured that the system we have introduced and that you are using in your hospital is indeed fit for purpose. Thank you for listening.